Welcome to part 3 of this EuroPCR wrap-up, focusing on transcatheter treatment of tricuspid regurgitation with the Edwards portfolio. My name is Nicolas van Mieghem from the Erasmus University Medical Center in Rotterdam, and together with me in the studio, Professor Philip Loerts from Leipzig Heart Center and Professor Philippe Rake from the Heidelberg University. In this part, we will focus on the challenges of transcatheter treatment of tricuspid regurgitation and then illustrate data on the use of Pascal, Cardioband, and also the transcatheter replacement system of EVOC in the setting of tricuspid regurgitation. And for this, I will hand over now to Professor Philippe Loerts from Leipzig. Philippe.
So, thank you, Nicholas. So when we move from the mitral to the tricuspid valve, we do not just move from the left to the right side of the heart, but we are also dealing with a slightly different anatomy and especially anatomical challenges. The tricuspid valve has certainly more dense chordae. The leaflets are very thin. The anatomy varies a lot, and these leaflets are quite fragile. And then thirdly, what we also encounter on tricuspid valve is that we normally have to treat patients with much larger coaptation gaps as we see on the mitral valve. Now, all of these aspects need to be considered for technologies when treating tricuspid regurgitation. The Pascal platform to treat TR is the same as it is for the mitral valve. However, the specific features, if you remember, of the Pascal device, which is a nitinol-based, very flexible system, being gentle to the leaflets, the ability to do independent grasping, and also the opportunity to elongate the system in full to get out of trouble when entrapped into cords, all of that is particularly helpful and handy when treating tricuspid regurgitation. And in addition to that, the stabilizing rail system, as demonstrated before, this system allows you to stabilize the three components of the Pascal system: the guide, the steerable catheter, and the implant catheter on a rail. And this rail also allows you to move in and out into the body without any additional adjustments. Very predictable and safe. Now let's look at the body of evidence for the Pascal system when applied on the left side to treat tricuspid regurgitation. And we do that in a chronological order. First, there was a compassionate use series in Europe, the US, and in Canada. And here you can see the 1-year results. Numbers are a bit small. These are 28 patients, but they all had a 12-month follow-up. And you can see that even after 12 months, and please consider that this was really the very early experience with not a lot of learning so far. Even there, at 1 year, 86% of patients with acceptable reduction in tricuspid regurgitation. And this is always important when we treat TR, the question, is it beneficial for the patients? And you can see that a clear reduction in NYHA class in these patients. We then move on to and look at the 6-month follow-up results of the CLASP TR early feasibility trial. We here look, when we compare baseline to 6 months, at 27 patients, and you see that 78% of patients had a reduction to moderate or even less. And here it is important to consider that a 5-grade scheme is applied in these patients. So some had really a reduction from grade 5 to grade 2. And again, a significant and marked improvement in NYHA class in these patients. Then we look at 155 cases, commercial results from 4 centers in Europe. And these study results of the class TR trial nicely reproduced at follow-up 83% with moderate or less TR, and again, a clear improvement in patient symptoms as illustrated by NYHA class. And then another single center real world study from the colleagues in Munich with 78 patients. And here really fantastic results when it comes to TR reduction down to moderate or less, 92% of patients, and similar results with the Pascal ACE device. And then the last single center trial from the colleagues in Heidelberg. And I think it's much more appropriate that these results are presented by the principal investigator. So I now would like to hand over to Philipp Rake.
Thank you very much, Philip. So this is the results from our center here in Heidelberg. So we have done around 40 procedures with the Pascal ACE device so far. So this is the first results from last year. And you can see that in this first series of patients, where we were successful, we have a good reduction of tricuspid regurgitation. So this is on the left side is the TR grade. First column is before the procedure, and on the right side is before discharge. And you can see that there's a nice reduction of TR in the majority of patients. And this corresponds to, on the right side, NYHA class. So the NYHA class was fairly reduced in these patients with using the Pascal ACE device. Thank you.
Wow, I think that this data clearly shows how elegant this technology is also to treat the tricuspid valve. And the tricuspid valve is a different animal than the mitral valve. I think that was clear from Philippe Lurtz's presentation. I was impressed by the effect on the residual TR. So over 80% of the patients had moderate or less severe TR. So that is quite impressive. Is this patient selection, are there patients that we need to avoid, Philippe Lurtz?
I mean, patient selection is absolute key. Yes, indeed. And even despite the fact that you have the opportunity to do independent grasping, that does not mean that you can treat extremely large coaptation defects, because at some point the degree of tethering will be too much to and will not allow you to come out of the procedure with an acceptable results. Having said that, I believe that you can treat patients with a gap up to 10 millimeters. Preferably those patients who have a more central jet or ideally anteroseptal jet. And in these patients with some experience, you can achieve exactly what's been presented here. And please remember, this is not just studies, but it's been reproduced at different centers. So I think 80-85% of patients coming down to moderate or less TR.
Philippe Rake, any suggestions on Pascal or Pascal ACE in the tricuspid space?
Yeah, so looking at the anatomy of the tricuspid valve, which is different than the mitral valve. So you have thin leaflets, you have a very dense chordal network, and you sometimes get entangled in the cords. And so we absolutely prefer the Pascal ACE device for the majority of patients, and that's where we start off. So usually that's our default device, is the Pascal ACE device for the tricuspid valve.
Important practical learning there. I think it's fair to say that our options are growing to treat tricuspid regurgitation. So let's move now to a different technology, an annuloplasty device. And for that, I'll give the floor to Professor Rake.
Thank you very much. So now let's switch over to an annuloplasty device, which is a little bit different philosophy in treating the tricuspid regurgitation. I think basically the idea is very appealing because the pathology of tricuspid regurgitation is annular dilatation, and this is what you treat with an alleloplasty system. And so we have used the cardioband system for the tricuspid valve. We have good experience with this device in purely functional pathology. The device was a little bit improved. So the anchoring devices which you need to anchor the cardioband to the tricuspid valve, depending on the size of the implant, it's 12 to 17 anchors. The anchor drivers were a little bit modified. They are not preloaded, so you have this anchor cartridge which you can load the anchor drivers yourself. This is a torque limiter which you attach to the anchor driver. The delivery system and stand was a little bit modified. The coloring and also the movement of the device. You can turn the handle when you go to extreme positions, which you sometimes have to do on the mitral or on the tricuspid side. You can easily do that, and you can turn the handle a little bit more, which makes the procedure a little bit more easier. Sometimes with the old system, you got stuck here with the fixator. This is a little bit easier with the overhauled device. And the fixator and the cradle was improved, which makes sterilization a little bit easier. And so overall, the system was improved. Regarding results, this is actually from the TriBand study. On the left side is the TR severity. On the right side is NYHA class. The first two columns is before the implantation of the device, and the right columns is for a discharge TR reduction. And so you reach at least a moderate TR in the majority of patients, and 59% in this case. And over 30 days, those results stay stable. And correspondingly, NYHA class is improved with this device. When we look at the real-world experience, which was presented here from Roman Pfister, you can see that on the left side is TR severity, again at baseline and discharge, with a good reduction, similar to what we have seen in the TriBand study. And this is also true for the 30-day results for these patients which reached the 30-day time point, and also NYHA class was reduced correspondingly. So I think it's important to have this technology on hand. You choose the right patient. I think it might be a good technology with the philosophy of treating the annulus.
So thank you, Philippe. In my impression, from my standpoint, it seems to be a little bit more time-consuming as an operator. So is the cath lab time longer with the cardioband?
Yes, that's actually a key point. So when I announce a cardioband system in the cath lab, so we have to plan a longer time slot for the procedure. So usually with a Pascal system, interventional leaflet repair, you are usually done in an average of 30 minutes for the pure procedure time. We have done this in 14 to 15 minutes in some cases. Sometimes it takes a little bit longer with the Pascal devices of a complicated anatomy, but usually you're done within 30 to 45 minutes at maximum. For the cardioband system, you need to calculate at least 2 to 3 hours, 2 to 3 hours. I think that's a time frame you need to calculate for the procedure. And you need a good echocardiography. So it's like implanting several devices, because you have to, every anchor you have to steer and you have to place individually. And the echo guy has to find the right position for defining the right spot for your anchor. And that makes the procedure a little bit more complicated and time consuming, that you have to take into account when you plan that procedure.
Mm-hmm. So before I hand over to Professor Lourdes to discuss transcatheter tricuspid valve replacement, it's clear that we are developing a toolbox to treat mitral valve and to perform mitral valve repair, and also to perform tricuspid valve repair. So last question to Professor Rake. Are these techniques, so the cardioband and the Pascal system, complementary? So do you envision in the future that we may combine both treatment techniques in one patient?
Yeah, so we don't have the data to say that yet. I think it's an appealing approach to first implant a cardioband and see if you reduce the annulus, and you might go for a second procedure to further optimize the result. I think we need clinical studies to do that, and at the moment we don't have that. So I think it's at the beginning it's really important to choose the right procedure for the right patient.
Mm-hmm. Yeah, well, I think intriguing concepts, and we'll definitely learn more about this in the next couple of years. So now let's move over to a transcatheter tricuspid valve replacement. I give the floor back to Professor Lourdes to discuss the EVOQUE data.
So we're now going to talk about the third tool in the Edwards box to treat tricuspid regurgitation, and this is the EVOQUE system. This is a percutaneous transvenous tricuspid replacement system. The delivery system allows you to position the device in a truly coaxial way in the tricuspid valve. The delivery system is brought forward, then can be bent, and is entering the right ventricle. By unsheathing the device, the valve is deployed, thereby the anchors, they wrap around the tricuspid valve. This is the essential anchoring mechanism. The device is then pulled into the annulus, further deployed, as illustrated here, and thereby in the best situation, not reducing tricuspid regurgitation, but really completely abolishing it. And as you can see here, these are the latest results, 41 patients, and it's really exciting to see, as said, and as compared to the other technologies, it's not a reduction in TR, it is a complete abolishment of tricuspid regurgitation. 98% had no relevant TR anymore. So this is very promising, obviously very early. It will be assessed in a pivotal trial, also compared to medical therapy. But if we see the same results there, then I think it yet again could be another gear change in the field of tricuspid regurgitant treatments.
Thank you, Philippe. That's very fascinating. When you see these data, is this the end of tricuspid repair, and we'll be only doing transcatheter tricuspid replacements? What is your take on this?
I'm 100% sure that these technologies, they will be complementary. I mean, we should not forget, it's always good to have as little foreign material in the heart as possible, especially on the right side. And I believe that patients you can treat nicely with repair in patients where you can achieve a reduction in TR down to mild or less. I still think that repair will be very important, because we know that we have very little safety issues. I think one thing which hasn't been said so far, Pascal implantation in a tricuspid valve is an extremely safe procedure. So for replacement, we have to see the same safety. It seems to be very safe, but there's some cases with AB block. We will see during longer follow-up whether there's an increased risk, for example, for endocarditis or also for thrombus formation. So I think in the end it will come down to the question, in what device will provide you with a TR reduction down to mild or even more. If you can do that with repair, I believe that repair might be still the first option. If you think that you will not be able to do that, only replacement will provide you with an efficacy as such, then it will be clearly replacement. This is obviously a speculation, as said, we are in a very early stage, but even more so very impressive what can be achieved with that technology, still being within a learning curve.
Yeah, but what I will keep in mind is that tricuspid repair is also here to stay, and we have this other potential with transcatheter replacement that also promises a lot for the future. So with that, I think I'd like to conclude this part on the transcatheter treatment of tricuspid regurgitation. I think it's fair to say that Edwards Lifesciences is developing quite a robust portfolio for the treatment of tricuspid regurgitation. We saw a very nice overview of what the Pascal technology can do for tricuspid regurgitation. Over 80% of the patients will have moderate or less residual tricuspid regurgitation, and this will affect the patient's well-being and might even affect overall longevity of these patients. I think it was also very interesting to learn that annuloplasty also works in the tricuspid space, and potentially we have been thinking about complementary techniques. Who knows? And I think the final discussion on transcatheter tricuspid valve replacement with the EVOC system opens up a new spectrum where we'll not only try to reduce the TR, but even abolish TR. I think with that, I'd like to close this section. Also, you can find even more EuroPCR content at the Edwards Lifesciences Hub, including the full Tools and Techniques series. You have access to all the presenters' slides, so the slide decks are available. There are the expert interviews, and there is also this interactive tool. So thank you very much, Radcliffe Cardiology. Thank you, Edwards Lifesciences, for inviting us and for a great set of presentations on the Pascal and Cardioband and EVOC technology. Thank you, EuroPCR, and thank you for staying with us. Have a good one. Bye.